I'm Dr. Kevin Campbell. I'm a Duke-trained cardiologist. I'm CEO of a medical data management company called PaceMate.
I'm Dr. Deborah Fisher. I'm a gastroenterologist. I'm at Duke University, and I run Duke GI research at the Duke Clinical Research Institute.
For me, I think one of the biggest issues is that in medicine, we're circling in a separate orbit around big data, around pharma, and we're all in our individual silos. And until we work together to solve patient problems, engage patients, we're not going to solve problems very quickly. If we could only put the patient at the center of the equation, this would all be possible. So if pharma and the digital providers and the physicians and the hospital systems and the insurers and the legislators, you put patients at the center of this equation, outcomes improve.
I agree. I think we've been very much in a box-checking mode. So there are certain aspects of technology that people feel they either need to have or was mandated that they have. But important things like interoperability, transparency, ability to work together has not been supported by the infrastructure or by legislation. So what does this mean, to patients and to doctors and to everyone else? It means that we have a number of different tools that are not connected. So you can have a patient portal that's connected to a physician's office but isn't connected to the hospital electronic health record, which may or may not go to different doctors. We have a ton of data, but it's not useful data in many cases because we can't connect it all together. We can't link it to the important things, the outcomes that we care about.
So I am so passionate about connecting the dots so that we're not going around in circles and going the long way around the street. We're going from point A to point B. And what happens? The patient does better. We reduce risk of death, hospitalization, and we reduce cost and burden to the healthcare system.
So in my world, I'm an outcomes researcher and a clinical researcher, and one of the things we've been trying to do is make clinical research better, faster, cheaper. So trials have gotten larger and larger, they've gotten more and more expensive, it's become more and more difficult to recruit patients. But in the meanwhile, we have physicians and nurses and medical assistants and other members of the healthcare team entering the exact same data for clinical documentation and also for billing. So why do we have one set of data for the clinical world and the business world and another set of data for research? This is duplicate work, and frankly, we can't afford it on either end anymore. We can't afford those expenses for patient care. We can't afford those expenses for research. What we need to do is be able to turn real-world data to real-world evidence, meaning that we use the same data, you enter it once, and it's of high enough quality, and people believe in the quality and the validity of that data, so it can be used not only to take care of your patient, but also to make research studies, to make regulatory decisions, to not have these parallel, very wasteful, very expensive, and it takes a longer time to get a drug that is a good drug to the patients to help them.